Jane. Jane is a new patient at your clinic and has come to see you as she has been unable to carry a pregnancy to full term. She is currently 35 years old and married with one sexual partner. She has had unprotected sex for 24 months. Within the past year, she has had 2 known pregnancies, both of which spontaneously terminated within the first trimester.
In Canada, 25% of recognized pregnancies result in a miscarriage. However, less than 5% of women experience 2 consecutive miscarriages.
She has seen her medical doctor and had a hormone panel done. It showed a low level of progesterone, and since then she has been taking progesterone cream, which has not been effective to date, and began taking a prenatal supplement. She has come to you because despite all of her efforts and research over the past 2 years, she still has had no success of carrying a pregnancy to full term. You would like to gain more insight into her nutritional status, so you run a full serum vitamin and mineral panel. The results come back and show that most of her vitamins and minerals are within the low end of the reference range in healthy adults, except her magnesium is still deficient. Despite her prenatal containing 50 milligrams, this is a concern you need to address.
What's so special about magnesium? Magnesium is the 4th most common cation in the body. It plays a fundamental role as a cofactor in more than 300 enzymatic reactions, and plays an important role in hormone receptor binding.
Magnesium's important for hormone binding, you say? So?
In animal studies, it has been seen that progesterone concentration drops before labor. However, in human studies, it was found that there was no apparent drop in progesterone concentration before the onset of labor. Instead, it appears that there is either a receptor deactivation or a change in the estrogen-progesterone ratios, which triggered the start of the cascade leading to spontaneous labor or spontaneous abortion. So maybe it's not simply Jane's hormones that are causing her infertility, but the ability of those hormones to bind appropriately during pregnancy.
While deficiencies can be related to poor absorption and dietary intake or increased loss from GI or renal causes, our bodies also have an increased demand for magnesium during periods of growth or during pregnancy. By the 90s, one study on 294 women experiencing multiple miscarriages had already identified a linear correlation between the severity of magnesium deficiency and the number of spontaneous abortions, showing that the more deficient a patient was, the more abortions they experienced. This finding has been confirmed by other studies that has also found that women who experienced spontaneous abortions had lower plasma magnesium levels than those who carried to term. However, it should be noted that serum tests for magnesium levels are not the most accurate way to assess the levels, as only 0.3 to 1% of total body magnesium is found in the serum. While serum magnesium can be a decent way to monitor magnesium levels during therapy, red blood cells have 3 times this amount, which makes measuring red blood cell magnesium levels a better measure for assessing status. Another study found that diabetic women are at increased risk for spontaneous abortions, perhaps due to the increased renal excretion of magnesium.
That being said, another randomized control trial concluded that magnesium supplementation had no effect on the outcome of pregnancy. Interestingly enough, the women in that study were in their 2nd and 3rd trimester. Yet, another study pointed out that magnesium supplementation is most effective during the 1st trimester, which is important to note clinically.
So what does this mean for Jane? While normal magnesium requirements for women are about 310 to 320 milligrams per day, during pregnancy it is advised that patients increase their intake to 350 to 360 milligrams per day. However, women who are experiencing infertility, the dose recommendation is much higher, sitting at around 500 to 1,000 milligrams per day. Given Jane's history and her low red blood cell magnesium levels, it is recommended that she increase her magnesium take from the 50 milligrams per day that is in her current prenatal vitamin to 1,000 milligrams per day. Is magnesium enough as a sole treatment plan for Jane's infertility? Perhaps not. One other important mineral should also be considered. In a small study done on 6 women with a history of unexplained infertility or early miscarriage, it was found that their red blood cell magnesium levels had failed to normalize despite 4 months of supplementation. These women were given selenium for 2 more months, in addition to their magnesium supplementation. And after 2 months, their red blood cell magnesium levels had normalized. All 6 women were able to get pregnant and carry to term. Therefore, it may also be advisable that Jane adds 150 to 300 milligrams per day of selenium.
That being said, there are many causes of infertility that require a multifaceted approach, and when looking at a case, it is important to consider both the male and the female involved. Remember that magnesium is not a blanket fix for all cases of infertility, and serum magnesium levels, while commonly used as markers in research, are not as accurate of an indicator of magnesium levels as red blood cell magnesium measurements. Magnesium is an important part of ensuring a healthy pregnancy, so even in patients who have not been experiencing fertility challenges, it is important to ensure that your patients receive adequate amounts of both magnesium and selenium.
As for Jane, magnesium was the missing link to her new happy family.